chest abbreviated injury score AIS greater than 4, a neurologic injury with a Glasgow Coma Scale score less than 8, and admission with a systolic blood pressure less than 90 millimeter of mercury. Thoracic trauma has an approximately 10% mortality rate. This is the trimodial distribution of trauma death. It includes three kinds of death. One is immediate, one is early death, one is late death. Immediate death occurs at the scene of injury caused by massive CNS injury or cardiovascular rupture. These injuries are typically not salvageable. Early death within 24 hours occurs within the first 24 hours with a cluster during the first golden hour, typically due to major thoracic injuries and also brain or abdominal injuries. Patients in this phase benefit the most from rapid resuscitation and definitive treatment. Late death occurs due to after days to weeks after the initial trauma, usually due to sepsis and multi-organ failure, often reflects inadequate or delayed resuscitation and treatment in the early phase of care. Abbreviated injury score. Uh, it has score 1 describe the severity of minor injury. Description is rib contusion or fracture, sternal contusion. AIS score 2 moderate injury, moderate severity, 2 to 3 rib fracture, stable chest, or multiple fractures of single rib or sternal fracture. AIS score 3 is severe, not life threatening. Rib fractures open or displaced or communicated more than 3 rib fracture with stable chest. AIS score 4 severe life threatening flail chest, and score 5 is critical survival, which are survival uncertain. See the severe flail usually requires ventilatory support. And these are the immediate life-threatening injuries and potential life-threatening injury. These are called as the deadly dozen, which divided into six under immediate life-threatening injuries and six under potential. These six are which are immediate life-threatening. These are airway obstruction, tension pneumothorax, pericardial tamponade, open pneumothorax, massive pneumothorax, flail chest. And potential life-threatening injuries include aortic injuries, tracheobronchial injuries, myocardial contusion, rupture of the diaphragm, esophageal injuries, pulmonary contusion. These injuries must be identified. The first six immediate life-threatening injuries should be identified and managed during the primary survey, and potentially life-threatening injury detected during the secondary survey. Early recognition and appropriate management of these injuries are critical for survival. Pathophysiology of the thoracic trauma. The pathophysiology response to injury is related to the primary mechanism of injury, which can be classified as uh, blunt or penetrating trauma. Blunt trauma usually caused by vehicle accident, falls, assault, sports, crush or blast injuries. Mechanism include injury severity is proportional to the kinetic energy or force involved. Common injuries are pulmonary contusion is the most common. It may include alveolar hemorrhage, parenchymal damage, and skeletal fractures, visceral rupture or aortic injury. Penetrating trauma is caused by direct mechanical force to focal area. It depends on the velocity and biomechanics of the projectile. Injury depends on size, shape, impact, force, and deformity or density of the body tissue as well as penetrating object. Severity influenced by physical characteristics of the weapon. Example velocity, size, and of the weapon. ATLS guideline, Advanced Trauma Support Guideline, includes the assessment of trauma into two groups, which are primary survey and secondary survey. Primary survey includes CABCD approach, which is for to identify and manage the most immediate life-threatening conditions. The first C um, stands for catastrophic external hemorrhage. Uh, Control exsanguinating external bleeding immediately should be done. A for airway with cervical spine protection. Ensure airway patency while maintaining cervical spine immobilization. B for breathing and ventilation, assess and support adequate ventilation and oxygenation. C for circulation with hemorrhage control, it evaluate perfusion, pulse and manage internal bleeding. D for disability, perform a brief neurological evaluation as per the GCS score. E for exposure and environment control, fully expose the patient to identify injury and prevent hypothermia. These the six has been described here. Exsanguinating external hemorrhage, these are from massive arterial bleeding, needs to be controlled even before airway is managed. It is usually done in the field of the trauma scene. Airway with cervical spine control, it is an immediate assessment of the patient's airway is made. A compromised airway requires a stepwise progression. First step is to clear the airway by suctioning the secretions or blood, followed by simple maneuvers such as jaw thrust, chin lips, and insertion of oropharyngeal or nasopharyngeal airway. Advanced airway maneuvers necessitate the insertion of a cuffed endotracheal tube. The cervical spine needs to be immobilized. As long as the cervical spine is not cleared by physical examination with or without diagnostic imaging, the spine should remain stabilized. Breathing and ventilation. All patients should receive a high flow oxygen. Life threatening chest pathologies such as tension pneumothorax, massive hemothorax, and flail segments should be diagnosed and managed immediately. Circulation and hemorrhage, blood pressure and heart rate are measured. Two IV lines are inserted and blood is obtained for laboratory investigation. In the search for internal blood loss, imaging can be very helpful. Radiological investigation such as chest radiograph and EFAST is necessary in this test. Disability GCS score should be calculated. The pupil assessed for size and reaction to the light and the patient observed to determine whether they are moving all four limbs. The core temperature must be recorded. Patients are managed with cervical spine protection with cervical collar or cloths and protection of the thoracolumbar spine using standard log roll techniques until a spinal injury has been excluded. Exposure environment and exposure represent hypothermia, burns, possible exposure to chemical and a radioactive system should be evaluated and treated. Secondary survey, it is conducted after primary survey is completed and patient is stabilized. Involves a head-to-toe examination to detect non-immediately life-threatening injuries. Additional investigation may include X-ray of the thorax, lumbar spine or extremities if indicated, and CT scans as needed. If the patient deteriorates during the secondary survey, repeat the primary survey starting from the airway. Key components of the secondary survey are chest wall assessment, palpation of the entire chest wall to evaluate flail chest segment, crepitus, soft tissue contusion, reef, sternum, or clavicle deformities. Sternal injury should be detected either fracture or dislocation present as it often indicates as point tenderness and step of deformity. Sternoclavicular joint injury is present as anterior dislocation, clavicular head prominence, and in posterior dislocation, compression of the thoracic inlet structures, hollowed out deformity. Hematoma, especially around the thoracic inlet if present, you should note the size and location and see whether it is progressing or not. Peripheral pulses, document all peripheral pulses bilaterally. Other areas to examine are axilla and back for hidden or small penetrating injuries and impaled objects. If impaled, example, penetrating into the chest, then those shouldn't be removed. Uh, Update on ATLS. It is now focused on judicious fluid therapy. Initially, 1 liter of fluid instead of 2 liter of fluid. Now they have changed, and it includes damage control resuscitation, which has 4 components: anticipate and treat traumatic coagulopathy, control permissive hypotension, limit crystalloid infusion to prevent dilutional coagulopathy, and damage control surgery. And the most important shine is shock. Shock is defined as a syndrome that is precipitated by a global decrease in perfusion that results in inadequate delivery of oxygen to tissues, compromising organ function. Early shock after trauma generally is a result of hemorrhage and a subsequent hypovolemia. After cardiac tamponade or TENS pneumothorax, compressive shock uh, can occur with with mechanical compression of the heart within the confines of the pericardium or thorax. Less common precipitating factors are cardiogenic shock due to myocardial failure and neurogenic shock secondary to loss of sympathetic tone. This is the classification of the hemorrhagic shock. These are of four types: class 1, 2, 3, 4, according to the blood loss and percentage of blood volume. If blood loss less than 75 ml, it is class 1. And if 750 to 1500, class 2, 1500 to 2000, class 3, more than 2000, class 4. Blood loss according to the percentage blood volume less than 15%, 15 to 30%, 30 to 40, more than 40. Pulse rate less than 100, more than 100. In class 3, it should be more than 120, and class 4 more than 140. And blood pressure for class 1, class 2, it is normal. Class 3 and class 4, blood pressure usually decreased. Respiratory rate 14 to 20 per chest raise per minute, 20 to 30 in class 2, 30 to 40 in class 3, and more than 35 in class 4. Urine output ml per hour more than 30 in class 1, 20 to 30 class 2, class 3 5 to 15, and class 4 negligible urine. Mental status anxious both in class 1, class 2, confused in class 3, and class 4 lethargic. Fluid replacement 3 is to 1 rule is crystalloid for class 1 and class 2. Crystalloid or blood both can be given in class 3, and class 4 mainly blood if not available crystalloid. And this 3 is to 1 rule is 300 ml of crystalloid solution for each 100 ml of blood loss. Management, the focus is on the control of hemorrhage and resuscitation of the circulating blood volume. After securing the airway, ensuring the ventilation, the search for possible sources of hemorrhage and volume resuscitation occur simultaneously. And in hypertensive patients, 1 to 2 liter of warm ringer lactate solution are infused and the response observed. In the according to the American College of Surgeons Advanced Trauma Life Support Protocol, the traditional 3 is to 1 rule suggests early resuscitation with a volume of crystalloid 3 times greater than the estimated blood loss. Transfusion is recommended if the blood loss is estimated to be greater than 25% of the total blood volume. In case of requiring massive transfusion, 10 units of blood along with 4 units of FFP and 6 units of platelets are given. Response. This is the fluid response to the hemorrhagic shock. Rapid response, transient response, no response. Vital signs normal is in rapid response, transient response, transiently improve, and no response remain abnormal. Estimated blood loss minimal less than 20%. If transient response is present, then blood loss estimation is moderate and ongoing, maybe 20 to 40% blood loss, and no response means severe blood loss more than 40%. Need for more crystalloid in rapid response is the low, transient response high, and raw response also high. Need for blood in rapid response is low, transient response moderate to high, and no response immediate need of blood. Need for operative intervention possibly in rapid response, likely in transient response, in no response highly likely. And in children 20 ml per kg ringer lactate given. The diagnostic test for trauma. First one is chest radiogram. This is portable, rapid, gold standard for general screening. Definitive diagnosis: pleural pneumothorax, any collection in the pleural cavity, lung parenchymal injury, fractures. These all can be diagnosed with a simple chest radiograph. E-first ultrasound. These are portable, extremely rapid, but this requires trained persons, and it can diagnose hemoperitoneum and pericardial effusion. And echocardiography, this is also portable, but it requires trained person, and Entire aorta and brachiocephalic vessels are not imaged. This definitive diagnosis for peripheral effusion, valvular and valve motion abnormality, and blunt aortic injuries. CT or CT angiography, these are having advantage of extensive imaging, which is required in multiple trauma patients. It can cover entire whole body also in one sitting. Emerging, these are the gold. Uh, uh, the disadvantage are transport to suit and contrast medium required, and it can diagnose all kind of thing like fractures, vascular injury, mediastinal hematoma, or trajectory of the missile in case of penetrating injuries. And angiography, this can give anatomic details, potential for percutaneous therapy intervention or not. And disadvantage is transportation, contrast medium needed, trained radiologist required, and it is slow. And definitive diagnosis are vascular injuries. First, the extended focused assessment for the sonographic evaluation of the trauma patient. Examination using four standard viewing ports, which are right upper quadrant, left upper quadrant, pelvis and subgyphoid, and extended views include left and right hemithoraxes. Bronchoscopy, flexible bronchoscopy is a highly effective diagnostic and therapeutic tool. It can be performed quickly with minimal sedation. Indications include suspected bronchial obstruction, foreign body obstruction, for traumatic bronchial injury, massive hemoptysis, continuous air leak or subcutaneous emphysema, toxic inhalation or burn injury, and iatrogenic injuries to the membranous trachea. This is the blunt chest trauma algorithm. If patient is arresting, then emergency department thoracotomy to be done, traumatic cardiac arrest algorithm to be followed afterwards. If patient is unstable, resuscitate uh, to a target of systolic blood pressure more than 90 by giving IV fluids, blood or FFP. Rule out other areas of blood loss, abdomen, pelvis, extremity, external, stop blood loss, and then trauma resuscitation algorithm to be followed. Uh, Rule out tamponade by ultrasound, pericardial effusion can be seen. Tamponade signs should be seen in the echo. If tamponade is there, then should be taken to the operation theater immediately. Pericardiocentesis to be done. If patient decompensated, then emergency room thoracotomy to be done. Tension pneumothorax, chest X-ray gives signs like deep sulcus sign, AR in the pleural cavity, and ultrasound also no sliding lung. And chest tube for if tension pneumothorax, needle thoracostomy should be done, followed by tube thoracostomy. Uh, and then next is hemorrhage or hemothorax. The blood in the pleural cavity can be seen in ultrasound, haziness in the chest X-ray. The chest tube should be put and followed by RBC, blood product transfusion. CT should be done to find the source of bleeding according to the how much quantity is there. Depending on that, any active bleeding is there or not. Depending on that, decide whether to take to surgery, surgical intervention needed or not. If patient is stable, then rule out critical diagnosis by doing chest X-ray, ultrasound, and to rule out tamponade, pneumothorax, hemothorax. See if unstable, then again those protocols to be followed, and other injuries to be ruled out by doing CT scan like blunt aortic injury, diaphragmatic injury, contusion, flail chest, refracture, tracheobronchial tree injury, and esophageal perforation. Blunt cardiac injury should be ruled out by ECG and troponin. If both negative, repeat ECG and troponin after 8 hours. And if both negative after 8 hours, then no further evaluation. And if either positive, then 24 hours monitoring with echo. Tamponade, this is the cause is the blunt cardiac injury, valve rupture or coronary injury. Symptom and signs may be asymptomatic or non-specific. Beck's triad, which include distended neck veins, hypertension and muffled heart sound. If these three are present in secondary survey, then we can suspect tamponade. Diagnosis, Bedside ultrasound is sensitivity is 100%, and echo shows the signs of diastolic collapse of the right ventricle with the fluid in the pericardial space, swinging of the heart within the effusion. Chest X-rays suggestive of enlarged cardiac silhouette, which is seen only in subacute cardiac tamponade. Treatment pericardiocentesis by taking to operating room. Tension pneumothorax cause is progressive accumulation of air in the hemithorax under pressure, causing compression of the ipsilateral lung, downward displacement of the diaphragm, displacement of the mediastinum, and severe respiratory embarrassment. Sign and symptoms include dyspnea, tachypnea, absent breath sounds, poorly moving hemithorax, subcutaneous emphysema. Diagnosis is upright chest X-ray, which shows deep sulcus sign, subcutaneous air, and the air in the pleural cavity. And E first in normal lung, in E first is shows positive motion or seesaw sign. In case of pneumothorax, barcode or stratosphere sign is seen, that is no motion in the lung. Treatment, a large bore needle should be inserted into the chest, preferably in the second intercostal space and in the mid clavicular line to relieve the tension, then followed by ICD insertion with underwater seal. This is the image how the needle thoracostomy done. The intercostal vessels are nerve located in the inferior border of the second rib. So middle area is the or just above the upper border of the third rib is the safest area to avoid the vascular and neurovascular bundle injury. Chest tube insertion is typically performed at the level of the fifth intercostal space on the lateral aspect of the thorax in triangle of safety, which is bordered by latissimus dorsi posteriorly, pectoralis muscle, major muscle anteriorly, and horizontal line at the level of nipple in the fifth intercostal space inferiorly. The skin is prepared and local anesthetic is administered, particularly to the subdermal region, till the periosteum of the rib and the pleural membrane. A small skin incision is created as shown in the image um, in the anterior axillary line just lateral to the pectoralis muscle or to in the case of male and or to the lateral mammary crease in females. With a curved clamp, the intercostal space is bluntly dissected and the pleura is carefully entered over the superior aspect of the rib. A finger is placed in the pleural space to ensure that pulmonary adhesions are not present, and then a chest tube, as per the 28 or 32 usually in case of adults, is positioned posteriorly and superiorly in the pleural space. Open pneumothorax, and open sucking wound open sucking wound occurs when a large defect is present in the chest wall. Equilibration occurs between intrathoracic pressure and the atmospheric pressure. This result in ineffective ventilation because air doesn't go into the that side of the lung. Rather, air is sucked into the pleural space from the outside environment. Management is this is managed immediately by closing the defect with a large gauze, Vaseline gauze, and a pad, and effectively seal off the wound with elastoplast. A chest tube should be placed, and operative closure of the wound should be performed. The signs might be cyanosis, respiratory embarrassment, sucking wound in the chest, and a shock. Hemothorax, massive hemothorax by definition is an immediate loss of 1500 cc of or more of blood into the chest cavity and may be due to penetrating or blunt trauma. Blood loss more than 1000 ml in next 1 hour or more than 500 ml in next 2 hours generally requires thoracotomy. Diagnosis are upright chest X-ray, around 150 to 200 ml needed in pleural cavity to diagnose any effusion is there or not. Supine X-ray sensitive to 40 to 60% ruling out pneumothorax. Ultrasound can diagnose as little as 20 ml of blood. Sensitivity 96% and gold standard is CT chest. The management of hemothorax in case of blunt trauma, it is divided into three categories: minimal, moderate, and major. Minimal is blood loss less than 300 ml, moderate 300 to 800 ml, and major more than 1000 ml. And minimal, in case of minimal blood loss observed if no progression, repeat films clearing of.
Right.
This. In case of increasing pneumothorax, Chest tube should be inserted. Bleeding stops, clearing, and no further treatment. If bleeding continues, exceeds more than 1000 ml, then thoracotomy is the indication. In case of moderate hemothorax, chest tube should be put, bleeding stops, clearing, and no further treatment. If persistent hemothorax, then thoracotomy. If continued bleeding, also thoracotomy. In case of major hemothorax, opacified hemothorax over 1000 ml immediate loss, unstable patient not responding to volume, continued loss more than 100 ml per hour after 6 to 8 hours, or loss more than 200 ml per hour after 2 to 4 hours, needs thoracotomy. Findings that require arteriography regardless of the state or volume of hemothorax are widened mediastinum, first fracture with pulse deficit or neurological deficit or expanding hematoma. Hemothorax in case of penetrating trauma, unstable patient, tamponade, hypertension over 1000 ml blood loss from chest tube, then thoracotomy is the indication. Stable patients in case of minimal hemothorax, observe no evidence of visceral injury, no further bleeding, no treatment required. In case of evidence of visceral injury obtained by arteriography, bronchoscopy, esophagoscopy, or contrast shallow, or especially X-ray, then thoracotomy to be done. Then pneumothorax or hemothorax more than 300 to 500 ml present, then chest tube to be included. Hemothorax evacuated, lung expand, no further treatment. If same continue bleeding more than 100 to 200 ml per hour, thoracotomy to be done. Airway obstruction. If any airway obstruction is there, then patient will be marked restlessness, anxious face, ashen gray color, or cyanosis may be present, stridor may be present, in drawing at suprasternal notch around clavicle in intercostal spaces and at epigastric region may be present. Remove any foreign body present in the upper airway, forward retraction of the tongue, insert upper pharyngeal airway, endotracheal intubation, and mechanical ventilation whenever needed. In gestual trauma, soft tissue injuries like laceration, abrasion, and hematomas are treated in the same manner as injuries to the soft tissue in other areas of the body. Subcutaneous emphysema, presence of gas in subcutaneous tissue. Treat the underlying cause. Do not make multiple cuts for subcutaneous emphysema with needle and puncture. The air in the subcutaneous tissue will gradually get absorbed in about 2 to 3 weeks time. Uh, this is the diagram showing how from where potential areas from where the subcutaneous air may originate. The first one is air may enter from the extrathoracic tissues from a pneumothorax through an injury or defect in the chest wall. Air may dissect towards forward the hilum along the perivascular form spaces from a peripheral alveolar or small bronchial injury. Air may enter the mediastinum directed from the injury in case of number 3 and from the track to the trachea or a major bronchus. In number 4, the air from the perforation in the esophagus will dissect upward through the mediastinum to the cervical area, which may cause subcutaneous emphysema. In number 5 image, air may enter the extrathoracic tissues through a penetrating injury not involving the lung or pleura. And 6 include injury to the segmental or subsegmental branches may result in air entry. Rib fractures, most common injury in blunt chest trauma. 10% patients have one or more rib fractures. Rarely life-threatening. It can be a sign of more several severe visceral injuries. Fractures ribs may cause hemothorax or pneumothorax. Commonly fracture at point of impact or posterior angle. Structurally at their weakest point, which is the weakest point. Ribs 4 to 9th are the most commonly injured. Fractures of the 4 to 9th ribs are associated with injury to the lung, bronchus, pleura, and heart, whereas fracture below the 9th rib are indicative of splenic, hepatic, or renal injury may be present. Refracture signs and symptoms are pain or tenderness may be present. External injuries may or may not present. Bony crepitus may be present. This is the chest radiograph showing on the left side it is a first refracture, isolated first refracture, and in the right side this is showing the multiple refracture on the right side. Uh, Then CT chest showing the left side showing the isolated first rib fracture, and right side showing multiple rib fractures. Significance of the first rib. The first rib has several attachments. Anterior scalene muscle attached to the scalenus tubercle as seen in the image. Middle scalenus muscle between the group for the subclavian artery and the transverse tubercle. Intercostal muscle from the outer border, and the subclavius muscle arises from the distal shaft and the first costal cartilage. First digitation of the serratus anterior muscle and the parietal pleura from the inner border, and costoclavicular ligament anterior to the groove for the subclavian vein. There is a groove subclavian artery and subclavian vein separated by the scalenus anterior and scalenus on tubercle with T1 root beneath the artery. And the sympathetic trunk, supreme intercostal vein, superior intercostal artery, and first thoracic nerve. These also pass beneath the first rib. This is the thoracic inlet, showing the showing the anatomy of the enlargement of the subclavian artery and vein in the thoracic inlet, and the relation to the first rib. First rib fracture has particular significance because of the great force required for it to occur, and the likelihood of that interthoracic visceral injury also has taken place. First rib injury in motor vehicle injury is due to violent contraction of the scalenus muscle by sudden forward movement of the head or neck. The two most common sets of the first rib fracture are subclavian sulcus and in the neck of the first rib posteriorly, uh, and which leads to the injury, which may lead to the injury of the subclavian vessels, neuro nerves passing through the neck of the first rib, including brachial plexus and sympathetic trunk. Subclavian artery or aortic arch angiography is indicated, or both can be done if the first rib fracture is displaced posteriorly, if the subclavian group is fractured anteriorly, or if there is widened mediastinum chest radiograph and an upper extremity pulse deficit with a concomitant brachial plexus injury or an expanding hematoma in the region. Management of the rib fracture. Treatment emphasizes on relief of pain, prevention of atelectasis, and optimization of the pulmonary toilet. Interventions favored for short-term pain relief include epidural analgesia, intercostal nerve blocks, intrapleural installation of anesthesia, and intravenous opiates as well as oral non-steroidal anti-inflammatory drugs. Chronic pain control is invariably required, which includes usually with oral narcotics, NSAIDs, and transdermal patches. Chest physiotherapy is indicated with incentive spirometry, suctioning of the pulmonary, suctioning to remove the secretion from the airways, along with bronchodilator therapy and steam inhalation. Surgical management of rib fracture indications are flail chest, defined radiologically as displaced segmental rib fracture with more than 3 consecutive rib fracture in more than 2 places, or clinically visible paradoxical chest wall movement. Multiple rib fracture with bicortical displacement, fractured rib acting as penetrating object, displaced rib fracture combined with sternal fractures, and or ipsilateral displaced midshaft clavicle fractures, uncontrolled pain with failure of non-operative treatment, chest wall deformity, especially with reduction of thoracic volume, acute respiratory distress syndrome in patient with thoracic case instability, displaced rib fracture found during thoracotomy for other reasons, chronic pain in case of symptomatic rib non-union. Such contraindications are hemodynamic instability, traumatic brain injury with GCS less than 10, infection, pleura, infections like empyema, mediastinitis, severe pneumonia, need for long-term mechanical ventilation for other reasons, unstable spinal or pelvic fractures because these fractures must be established prior to surgical correction of refracture. Relative contraindication, severe pulmonary contusion of the contralateral lung, contaminated surgical field, local infection of the anterior chest wall outside of the surgical field, fungal colonization of the mediastinum. Performing the surgical procedure within the first 3 days after trauma is recommended because inflammation and callus formation have yet to begin, and therefore fracture reduction is less difficult, leading to technically easier procedure. Materials reprocessing system, there are three types: rigid, expandable, and custom made. Rigid include titanium, steel, and polymethyl methacrylate. Expandable are the vertical expandable prosthetic titanium rib. Custom made are processes are 3D printed or custom designed processes according to the patient's anatomy. Other materials used are screw, sometimes intramedullary nails, and Krishna's wares are used. Titanium plates are the standard for the gestural fixation. Compatibility and other reprocesses are the oldest one, the Borelli steel staple splint system and the Strato system. Technique of refracture are open reduction and internal fixation of the fracture. Patient could lay supine, full lateral or semilateral depending on which ribs and which part of the ribs need to be fixed. After receiving the preoperative antibiotic, an incision is made over the fracture to be fixed. Muscle division is minimized to preserve respiratory function. The fracture are exposed and non-viable bone removed. The periosteum is left intact. The fractures are reduced and a broken rib segment are reapproximated. The thickness of the rib is measured with a caliper. The length of the screw is chosen by adding 2 mm, accounting for the plate thickness to the rib thickness. The appropriate rib plate is chosen and bent according to the contour of the rib. The plate is then positioned on the rib, studding the fracture with holes for at least 3 screws on each side of the fracture. The drill guide is attached to the plate and the appropriate drill bit is used to create holes in the rib. The drill guide is then removed and the appropriate screw is inserted with the help of an electric screwdriver. Preferably, at least 3 screws are applied on each side. If the wound doesn't expose part of the plate well, separate holes may need to be created on the skin to insert the drill or screw to avoid excessive enlarging the incision. The screws are finally hand tightened to ensure secure application. Other procedures such as bronchoscopy, drainage of pneumothorax, drainage of hemothorax, or decortication may be needed to done concomitant with the refractive fixation. This is the image showing how the lip plates are fixed. And the first image showing the exposure of the fracture fragment. In the second, the fracture fragment is uh, um, the the which is if non-viable fracture fragment is there, that is removed. And the third image showing the approximation of the remaining bone. And in the fourth image, the measurement and contouring of the plating is done in the 4, 5, and 6. And after that, the screw, with the help of the screw, the holes are made on the rib, and then then the screw is fixed on the ribs, and after that the plate is fixed. Then this is the one more image how the uh, uh, screw are in the place with the plates, and this is the right side of the image, the whole settings how the it comes. What is Plelches? It is the fracture of three or more ribs at two sides, either unilateral or bilateral, promoting enough instability that the thoracic case exhibits with paradoxical motion locally. A flail chest is invariably caused when the thoracic case absorbs high kinetic energy, and thus it is an important marker for significant intrathoracic injury in the patient with blunt trauma. It is highly associated with pulmonary contusion, approximately 45% of the patients. Pneumothorax or hemothorax is a common acute sequelae, and ARDS occurs in as many as one third of the patients and results in mortality rates are high as 33%. In this image, you can see the fractures of the second to sixth rib in multiple sites, more than two sides, causing a flail chest. Lack of movement of the flail segment during spontaneous breathing frequently observed on physical examination in non-obese patients. The segment that doesn't move with the rest of the chest wall has been described as having a paradoxical movement. In reality, the flail chest segment doesn't move much at all due to the discontinuity with the rest of the rib cage and its contact with the underlying contiguous segment of the lung. This is the video of the how the flail chest can be seen. You can see the other rest of the chest while moving except that part of the chest. Stoven chest is a rare and complex type of flail chest injury where the flail segment collapses into the chest. It is usually due to the severe blunt trauma to the chest wall. The injury severity score in patients with a diagnosis of flail chest has been found to vary from 30 to 36. Shock present in 41.2% of the patient, pulmonary contusion in 55.9%, ventilator support is required up to 70% cases, mortality rate is 5 to 32.4%. Diagnosis can be confirmed on a chest radiograph showing the fractured rib segment. CT scan may be useful since it has the additional ability to identify the other injuries. Yeah, management challenges in management of the patient with flail chest are problem of ventilation perfusion mismatch, maintaining adequate pulmonary toilet, adequate but not excessive fluid resuscitation, pain management, a decision regarding possible surgical chest wall fixation. Management include adequate analgesia either by IV analgesia or epidural anesthesia, oxygen and sprinting to be done, chest physiotherapy, incentives, spirometry, suctioning to remove the secretions from airway along with bronchodilator and steam inhalation, internal fixation by positive pressure ventilation, mm, adequate fluid resuscitation and surgical fixation. Is endotracheal intubation commonly needed in flail chest? Yes, it is required in more than two-thirds of the patients with flail chest. And what the indication, absolute indications of the intubations are respiratory rate more than 40 breaths per minute and PaO2 more than 60 millimeter of mercury despite 60% face mask oxygen. Relative indications are shallow respiration, depressed consciousness, pre-existing chronic lung diseases, presence of associated injuries. Surgical stabilization indications are patients who require thoracotomy because of associated injuries. Second is patients with deteriorating pulmonary function despite aggressive clearance of bronchial secretion and adequate analgesia, requiring internal pneumatic stabilization and without pulmonary contusion. Intubated patients with previous severe pulmonary contusion and cerebral injuries in order to reduce the duration of the internal pneumatic stabilization when patient fails to win from the ventilator. Patients with extensive anterolateral fail chest and progressive dislocation of the fractured ribs in order to prevent late cestual deformity and a consequent restrictive disorder. The primary endpoint of surgical stabilization of flail chest is the resolution of the paradoxical movement of the involved chest segment. This is a case which came to our hospital, a 55-year-old male with RTA, two-wheeler versus four-wheeler. After chest X-ray and CT chest, which was suggestive of Stoven chest with left-sided multiple fracture involving second to seventh rib, with left side scapular fracture and left side pneumohemothorax. After that, ICD was inserted, and this is a CT scan image at findings, which was suggestive of displaced fractures of left second to fourth rib, lateral and anterior aspect, displaced fracture of the left fifth to seventh rib, lateral and posterior aspect, some fragment displaced into left pleural cavity, lung and pleura collapse consolidation of adjacent lung segments with mild left hydropneumothorax, scapula comminuted fracture in the inferior left scapula, minor subcutaneous emphysema of the left lateral neck and chest wall. This is the 3D reconstruction of the CT. which is showing the multiple fractures from the second to seventh rib. So this is the intraoperative finding, which was showing undisplaced second left secondary fracture laterally, displaced left third rib fracture at two places, anteriorly and posteriorly, displaced left fourth rib fracture at three places, anteriorly two and one was in laterally, displaced left fifth rib fracture at four places, anteriorly two, laterally and posteriorly one. Two fragments of the fifth rib impinging onto the visceral pleura, causing tears of the visceral pleura and long parenchyma approximately 3 into 0.5 centimeter over the left lingula, which can be seen in this image. Displaced left 6-3 fracture at two places and minimally displaced left 7-3 fracture at two places. Edema fluid accumulation in the intramuscular and intermuscular spaces. Under all aseptic percussion and under GA with patient in right lateral position with extension of the arm forward and overhead, thoracoplasty incision was given and dependent layers to reach the thoracic case. Impinging fractures, fragments of the left fifth rib onto the lung parenchyma were removed and by blunt dissection, and tears in the visceral pleura were closed with using theophylacel and theoprolol, which is seen in the image here that the pleura is after suturing the pleura. And third to sixth rib fracture fragments reduce smaller mandibular plates and steel wires used to fix the third and sixth rib, which is seen in the image. And implant fixation with three plates was done over the fourth rib using screw and steel wires. Two drains 24 and 28 French drain was inserted in apical and basal position. Then followed by implant fixation with three plates was done over the fifth rib using screw and steel wires. Second and seventh rib fractures were not fixed as they were displaced. This is the chest radiograph of the patient after the fixation of the rib fractures. Sternal fracture, isolated fracture of the sternum and seen with increasing frequency in motor vehicle accidents, particularly since the passing of the mandatory seatbelt legislation because of the rapid deceleration that occurs from this mechanism of injury, especially in vehicles with absent or malfunctioning airbags. It presents a point of tenderness, edema, and obvious deformity are occasionally detected on physical examination, but a lateral chest radiograph is diagnostic in majority of patients. Morbidity and mortality from isolated sternal fracture is low, and surgical repair is uncommon, which is less than 2%. Management, as with rib fracture, the management is primarily supportive. Most fractures are transverse, involve the sternal manubrial junction or upper third of the sternum, and stabilize with pain control. Unstable fractures, such as fractures associated with chronic pain or those associated with infection, indicated by a new sternal click in the setting of fever or erythema, require operative intervention. Options include OAS in figure of 8 fashion, plates, or both. Longitudinal fractures may require close or similar to closing a sternotomy incision. Sternal fractures complicated by mediastinal abscess require debridement. Simple approaches include placement of an irrigation system, but recalcitrant or widespread infections require closure with muscle and or omental flaps after widespread debridement. This is the image showing the necrotic bone at the site of non-union was debrided, followed by a bone graft inserted into the sternal defect. Two straight sternal plates were applied for the internal fixation. Thank you.
Thank you, Swati. That was quite an extensive presentation. The initial portion of the primary survey and the secondary survey is extremely important, especially when we see a patient with trauma, it is not only the chest trauma, but also other organs. So you must have an idea of what happens in the head injuries, what happens with the abdominal injuries, especially the liver and splenic ruptures, as well as the pelvic ruptures, and then as well as the limb injuries and the vascular injuries along with the limb injuries. So this is very important. The one thing that you all should know is uh, less than 10% of chest trauma patients require a thoracotomy. And those requiring thoracotomy is already mentioned. And the important thing is massive hemothorax, which is with continued bleeding. Secondly, a massive internal injury, which requires an operative management. And then, of course, the cardiovascular injuries, which may be causing exsanguination or severe bleeding. So then also the importance of the first rib fracture. The importance of the first rib fracture is that when you have a first rib fracture, that means the force of injury is very, very severe. Otherwise, generally with an ordinary injury, the first rib will never get fractured. So when you see a first rib fracture, you can imagine that there is a lot more force and there will be a lot more injuries internally as well as other areas. So that gives you a clue to assess these patients well. And of course, as Swati has already said, neurovascular injuries is the most common thing with first rib injuries. Then comes the surgical management of rib fractures. Nowadays it has become a fashion to fix all rib fractures, because especially it is decided or directed by the industry, because they want to sell more of their implants and things like that. So they will do the market it so much. But you must understand that the major indications for rib fracture is a severe flail chest and severely displaced fracture ribs, maybe or causing a stove in chest and internal injury, or a thoracotomy is required for some internal injury, and on the way out you would like to stabilize and fix the chest wall. So these are the main indications for isolated single, double, or even three rib fractures. It is not an idea, not necessary to fix these fracture ribs. Of course, nowadays in many corporate hospitals, this has become the norm. And as I said before, it is all directed by the industry. Then ventilation in flail chest. Ventilation is one of the usual modes of treating flail chest. Because the older technique of stabilizing with a pulley and towel clips and pulley and weight hanging around the side of the bed is all given up. Ventilation is internal splinting with positive pressure. And once you have done an internal, ventilation for a flail chest, it is mandatory. Remember, it is mandatory to not to extubate these patients before 3 weeks. So until the soft callus forms, otherwise you will have the same problem and then it become a C. So if you do an early extubation, they will go back to the flail segment, and then that predisposes to non-union of these ribs in the long term. So ventilation should be done for a minimum of 3 weeks, and that necessitates doing a tracheostomy on the 5th or 6th day, and then subsequently manage them on the ventilator and gradually wean them off after 3 weeks, because you have to train them back to breathing well on and off the ventilator for a couple of hours, and then slowly ventilate off during the day and ventilate during the nights with SIMV and then slowly bring them out. So this is important in the management of ventilation in flail chest. Sternal fractures, yes. Most of the time they may require stabilization, and of course you have other, apart from the plates and other things, there are newer techniques of 3D reconstruction of prosthetics with the prosthetic material. I think it's called PEEK, PEEK compound, where you can actually do a 3D reconstruction of the sternum with the CT scan template, and then use it for fixation. So that those are the things that has to be followed. Yes, of course. There are a lot more things about chest trauma, and as you have earlier communicated that you have split it into two parts, it's good. So we come to the other areas of tracheobronchial injury, aortic injury, esophageal injury, diaphragmatic injury as a separate topic because it becomes very extensive. So is there any comments from any of these people, any of the seniors? Exam going people? You all must take active part, as Dr. Pradeep Narayan said last time. I think we should get into one of you as the fifth or sixth year persons will be moderating. In future, I'm going to do that as a thing. Person who is going to present, and there is to be one of you who has got to moderate and ask relevant questions so that other people also understand what are the questions to be asked. Okay, so we will draw up a format, and then that doesn't mean only two of them will be reading. Everyone should come prepared and read. And we should start asking random questions, because that is what we used to do earlier when we were having case presentations. Randomly, we used to ask questions. So I think we should go back to that system. Any further additions, sir?
No, it's well presented, especially the chest trauma is never isolated. So it's usually associated with other injuries. So it's important for the paramedics to diagnose it on the spot, treatment on the spot, then in the outpatient, emergency and other things. The most important thing is that the clinical assessment, because the most dangerous ones are one, tension pneumothorax, two, cardiac tamponade, three, flail chest in this. The other one comes the acceleration, deceleration, injuries of the aorta and other things. But in this, mainly nowadays, this is caused either by high-speed motor accident, falls from heights or even from level grounds, in scuffles, uh, or in blast. So the important thing is on to diagnose clinically. You didn't mention much how to diagnose tension pneumothorax. It's mainly diagnosed by the shifting of the mediastinum, the trachea, and the apex beat. Then the because of the air percussion of that area where there is tension pneumothorax, absent breath sounds. So these are the important things to uh, clinically make out before you say investigation chest X-ray. And also cardiac tamponade, of course, that you mentioned, the Beck's triad, clinically diagnosed a cardiac tamponade. And the other things, the pathophysiology, we were all taught that the main reason for flail chest causing the abnormalities of ventilation is because of mainly because of the paradoxical respiration. If the three ribs are fractured in two places, three or more, we were all taught that it causes a paradoxical ventilation. Otherwise, we used to call them pendulums. That means during inspiration, this independent column of chest wall moves inwards. Normally, during inspiration, the chest wall should go outwards. But when there is a flail, that segment goes in. So what happens? That compresses that lung. So much so when you take a deep breath, as fresh air enters from outside the atmosphere, because this segment compresses that lung, the air, the expired air from that lung goes to the other lung. So it's and during expiration, exactly opposite happens because during expiration,
Yeah.
so that goes like a pendulum effect. This causes a lot of deoxygenation. This was our always taught us, but nowadays, as we said, 60% of them may have contusion of the lung. So that also leads to deoxygenation of these patients. Also, the pain and not breathing well. And sometimes you do a fixation within 24 hours, but very often what we do internal splinting by a intubation and positive pressure ventilation. In that case, we have to ventilate, as Krishna said, at least 3 weeks. Sometimes, uh, instead of going on for 3 weeks, a few days later, you try to fix the ribs as you showed in your pictures, This is what's done. And the other thing is that all the time textbooks and all we used to say that for a tension pneumothorax, the way is to compress by needle compression in the anterior axillary line in the second intercostal space. But now most of the people do it on the mid axillary or anterior axillary line in the fifth intercostal space. The main reason is that the anterior, it's all covered by the thick pectoralis major muscle. You said when you do a needle aspiration, it should be on the upper border of the lower rib rather than the lower border because of the vascular structure. In the anterior axillary line, it's almost difficult to find out because it's thicker. And ideally, if you do on the fifth space in the anterior or mid axillary line or a point between that, it's much easier because the muscles are thinner. You can actually find out which is the upper border of the lower rib and do the needle aspiration or even just intubation through that, the intercostal intubation through that point. So I don't know what Krishna will say, which is the best anterior axillary line or on the fifth space lateral.
So the fifth space in the lateral aspect is ideal because the patient lies down and in the back and then that is the least obstructive area and then the patient is comfortable with the ICD coming out of the bed. Second thing, the reason why fifth space is chosen is that becomes the most dependent area when the diaphragm moves up during expiration. So whatever collects above is all drained in the ICD. So that is the reason why we choose the fifth space. Next in Swati, you talked about sternal fracture. Sternal fractures are most common with road traffic injuries. Before, it used to be very common before the seat belt. So we used to have what is called as sternal, steering wheel injuries. So that used to be the most common things, and you will have a nice round contusion on the chest wall in the front. Outside it looks very innocuous, but inside the whole sternum would be shattered and there would be severe laceration of the lungs and along with maybe plus or minus cardiac injuries. So that is important. So one thing to remember in all trauma patients is there is something called natural selection. If the patient usually very, very severe injury, they usually die at the site of the accident. But if the patient reaches the hospital, that means there is a chance to salvage these patients. So you must be aware and well equipped to do all that is in your possession to do everything to salvage these patients. So that is very important. Next, another comment I wanted to check with you people. Whenever we did massive transfusions, we always used to supplement with some calcium later on after 2 or 3 pints of blood. I am not sure whether that is practice now, or is there a change in the philosophy of that? Anybody can tell us?